Hi guys, welcome to another session. Today we're going to look at the drug Dabigatran or Dabigatran, depending on how you say it, and it's a direct thrombin inhibitor. We'll have a little look at the presentation, we'll have a look at the mechanism of action, we'll have a look at its usages and some of the common side effects, we'll have a little look at pharmacokinetics, and then from an ITU point of view we'll have a look at reversal in overdose and how we go about doing that. From a presentation point of view, Dabigatran comes in the form of Dabigatran etexylate. It's a coloured capsule, and the dosages range depend on what you're using it for. The capsules typically are 150 milligrams down to 110 milligrams down to 75 milligrams. One of the benefits of Dabigatran, as with the other NOACs, when compared to warfarin, is that there's no ongoing monitoring process. And in fact, there's no blood test currently that gives you a predictable indicator as to how well somebody is anticoagulated with the NOACs. What we do know, though, is they behave in a very predictable pattern, and therefore we know that the anticoagulation from them is safe. The mechanism of action of Dabigatran, as I've said, is a direct thrombin inhibitor. What that means is it blocks all of the free and fibrin-bound thrombin within the circulatory system. As you can see from the diagram on the screen, that's at the latter part, the common component of the coagulation cascade. Dabigatran has no effects on the intrinsic or the extrinsic pathways within that process. When we're thinking about the uses of Dabigatran, initially it was licensed for VTE prophylaxis in people who had knee and hip surgery. That license was extended. It's now available in VTE prophylaxis against stroke in people with atrial fibrillation. And the benefits of that was proven in the Relay trial in 2009 from the New England Journal. It demonstrated Dabigatran was as good, if not better, than warfarin at equivocal dosages in preventing the risk of stroke, and it also was found to have a lower risk of bleeding overall. Dabigatran now also has a license in the treatment of venothrombotic events and also in the prophylaxis beyond that also. One of the common side effects, which is common to all of the NOACs, is an increased risk of bleeding, although as we said in the Relay trial, the risk of bleeding is slightly lower than that of warfarin. There's also a common side effect amongst the NOACs that's GI upset. About 35% of patients will get GI upset from using Dabigatran, and that's just something to be aware of. When we think of the pharmacokinetics, Dabigatran etexylate actually is a prodrug. It gets metabolized down by plasma and hepatic enzymes down into the moiety drug of Dabigatran, and that is where most of the action is carried out. Once that metabolism has been completed, there's no further processing that's carried on, and it's then renally excreted. So one of the issues with Dabigatran is if you've got renal failure, you shouldn't be using it. Anyone with a creatinine clearance of less than 30 or a GFR less than 30 shouldn't be using Dabigatran because they have specific difficulties in processing and excreting that drug. And finally, when we're thinking about reversal of Dabigatran, there is now a license for a reversal agent that wasn't there before. It's called idarucizumab. It's a monoclonal antibody, and its use was demonstrated in the reversal AD trial that was carried out last year, 2017, compared to the previous other methods we were using. From an ITU point of view, it's important to note that Dabigatran has a low plasma protein binding status. Therefore, it's ideal for hemofiltration and hemodiafiltration. So if you get a VASCATH in quick enough and you can control the bleeding well enough, you can dialyze a lot of this Dabigatran out of the circulation if the patient group is appropriate. In the absence of these two interventions, the British Haematological Guidelines still state that you should use PCC or recombinant factor 8 if you've got nothing else to use. And obviously, alongside all of these are the supportive measures. Depending on how much the patient is bleeding, depends on how far you need to go down this reversal pathway.